right, I'll try and speed things along. I know everybody's ready for a break. Just as an FYI, I will be focusing this talk primarily on type 1 diabetes treatment. I've excluded, for pretty much all intents and purposes, all type 2 diabetes treatments. They are different in how they are treated, especially initially, and my perspective is strictly on type 1. So the reason that I'm here and providing you with my perspective is because this is my family. My husband, my son, and my daughter, all three have type 1 diabetes. So I'm usually a little bit tired and a little bit broke. And so my husband was diagnosed at age 29. My son was diagnosed at age 20 months. And my daughter was diagnosed at 6 years old. And that was our order of diagnosis. We have learned a lot about the diabetes world, particularly for me, even after my kids were diagnosed. My husband, he just took care of himself. I knew about insulin, I knew about treatment, I knew about diabetes, but he really just took hold of the reins and took care of himself. When it came to the kids, I really started learning a lot more about terminology, and I will tell you some of my slides are very dense, but we will pick and choose the highlights for those slides. The first thing I wanted to do is just provide you with a little bit of terminology. Across the board, what I've noticed is that nurses and OTs and many physicians know very little about the treatment of type 1. So the first thing we're going to mention is that there are two main types of insulin. There's a short-acting insulin, which is used for the most part for treating carbohydrate intake, high blood sugars. You're going to get a fast response. I want to highlight one drug that's the newest drug on the market, which is called Fiasp. Fiasp was approved in 2017. It is the most fast-acting insulin on the market, and usually you'll see it becomes effective in about 20 minutes. I've also highlighted in the short-acting insulin, this is one called Novolin R. And I'm highlighting that because we'll talk a little bit later about the infamous Walmart insulin that is being discussed as a cure-all fix for the cost of diabetes care. There's also long-acting insulin, and for anyone that is taking injections, they will require a long-acting, what we call basal insulin, their background insulin. The most common one that's used right now is Lantus, although there's a new competitor on the market called Basaglar. And again, we do have another Walmart insulin called Novolin N that has somewhat of a longer acting profile, but we'll see later that there are significant problems with these two types of insulin. The basal insulin is going to be the background insulin. Every person in this room requires that basal insulin in order for you to survive. So there's no negotiating here. You must have it for everyday life. A bolus is another term that we use. We give a bolus of insulin anytime someone eats, or we give a correction, which is like a bolus of insulin, if a blood sugar is too high. I do want to talk a little bit about two other things. I want to talk a little bit about insulin pumps. So there are several different insulin pumps on the market. Insulin pumps use short-acting insulin to deliver a continuous basal or background dose of insulin. The insulin pump uses a short-acting insulin by basically us setting measurements in this pump to determine how much this person needs across the day to be able to sustain, quote unquote, a normal blood sugar. Normal blood sugar ranging, in our case, between like 80 and 150, okay? When you look at insulin pumps, they allow high specificity. So my son at 20 months old, he didn't need a ton of background insulin. We had 13 different settings on his pump across a day to adjust his insulin based on his needs. If you look at the second function of insulin pumps, they allow for auto calculation of dosing for carbohydrates after a meal. So my kids can add up if they need to, say I ate 10 grams of this carbohydrate and 15 grams of this, and it will add it, and it will calculate automatically the dose that they need, and it will deliver that dose for the kids, which is important for my 5-year-old and my 10-year-old. It takes a lot of the stress of calculation out of their hands, and it makes them more independent. I wanted to show you real quickly. Here on the right-hand side of your screen, you're seeing my daughter holding her insulin pump. And you can see that she has a tube coming out of that pump. It inserts into a site that is put into her leg or her belly or her butt every 3 days. And so you can see that that's how we plug it in. It's all touch screen, the type of pump that we use. So she can just unlock, press, and go. The next thing I want to talk about is the presence of these things called continuous glucose monitors. And in my opinion, these are the absolute game changers in the business right now. Continuous glucose monitors, and I'm going to focus on the one called the Dexcom, essentially insert a sensor underneath the kid's skin, and my husband, I always leave him out, right? Underneath their skin. And it records their interstitial fluid glucose levels every 5 minutes, 24/7. And so what we'll see in this next picture is that each dot down here on the bottom represents a blood sugar reading. And that information, you can see, is telling me that, oh, he's 111, but he's going up a little bit, nice and slow. Just keep an eye on it. He should be good to go. It'll also tell us trends. So I can download all of this information onto a website through Dexcom, and it will say, between 6 and 9 p.m., he's trending to be a little high. Maybe you want to consider changing his background insulin or changing his dose. The other thing that is critical about these sensors is this one right here. It actually happened, this picture, the Saturday night, I think it was, that I was finishing up my talk, right? So it was after 9 p.m., you can see the time on the bottom, and my daughter's blood sugar just plummeted. It was kind of out of nowhere. She didn't have a ton of insulin on board. It was just one of those things that surprised us, and she tanked. Her blood sugar was down around 20 to 30 when she was caught with the Dexcom monitor. That Dexcom reading will then send an alert to my phone and my husband's phone and even my mom in Michigan's phone to say, hey, she's low. Make sure you get up and treat this. So we now have the ability to identify immediately when a blood sugar is too high or too low to give treatment immediately. And if this would have been a normal night and we had no Dexcom, we wouldn't have even known that was happening until we maybe checked our blood sugar a few hours later, or she woke up because she didn't feel good. So in my opinion, this right here is the absolute most important thing other than insulin. Now, we have other forms of glucose sensors, and I'll just mention those a second. There's one called the Libre, which is gaining in popularity. It's going to be one that I think we'll see a lot in the future as integrating with insulin pumps, talking with insulin pumps, and basically allowing for continuous glucose control in a closed loop system where the Dexcom or the CGM talks to the pump and says, you're high or you're low. I'll auto-calculate how to adjust for that. Now, I think that if we want to talk about the financial barriers associated with type 1 treatment, insulin by far is the one that receives the most recognition. Fortunately for us and our family, it is a hot topic right now in the media. We're hearing a lot about people going to Lilly and fighting against their insulin costs. And it's great to see that recognition is coming. I've put up here a receipt from I have a lot of stuff in here from Facebook. I'm part of a lot of Facebook groups. A receipt for 1 month of insulin as $1,092. We had a time in our family where we were paying $1,300 a month for insulin, and it's non-negotiable. So you do whatever you have to do to make that payment happen. Along with the insulin issue is that we have the same insulin across the world. There's nothing new or different in Europe or New Zealand that we don't have here. So this is just a rough estimate. If you look at similar costs of dose of insulin across the world, you can see that if I was to move to Norway, I would have to pay nothing. You can go pretty much anywhere in the world and receive cheaper insulin, and we'll talk about how that's actually impacting people's lives now. And in the United States, I'd say we're probably right around more like $400 or so in a lot of cases after insurance. So insurance doesn't necessarily help you in this case. We have a lot of other things that impact our treatment costs. You hear about blood glucose meters, so you need to check your blood sugar, so you need a test strip, you need lancets. You need alcohol swabs so that you can clean your finger, especially for my 5-year-old who always seems to just be dirty, right? I don't know how he does that. But I also want to point out our life-saving medication. In this case, our life-saving medication is glucagon. Glucagon, when we had insurance several years ago, cost us $300 each time. Again, that is what's going to save them when that low blood sugar is so low that my kids become unresponsive. The nice part is that there is a new drug on the market called Baqsimi, just recently approved. It's just recently being prescribed. It is an intranasal glucagon, which takes a lot of the pressure out from trying to prepare an injection during those times when you're in extra high stress with the kids and my husband. Bless his heart, right? Okay, so I also want to point out real quickly that I've mentioned to you that insulin pumps, in my opinion, are important, and that continuous glucose monitors like the Dexcom are important. So if you look at an insulin pump, this is the price after coverage with insurance. So for my family, we paid out of pocket roughly $7,000 to $8,000 just for the pump. This is another individual who also paid $8,000 out of pocket after insurance. So the real retail cost is right around $12,000 to $15,000. Again, it is considered a luxury, and it shouldn't be considered a luxury. The treatment that my kids have and my husband is way, way better having this pump where we can really, really dial in what they need. If my kids are going through a growth spurt, we can increase their basal on their pump and accommodate and prevent those high swings in blood sugars that they would normally have. I want to mention that glucose monitors are also very expensive. I'll show you on the next slide. After insurance, you're looking at probably $80 per sensor, depending on the sensor that you're using. That can last anywhere from about 10 to 14 days if you use your tricks and tips to try and manipulate the system. I'd also like to point out that it's pretty standard for all type 1 diabetics to go to the doctor pretty often. My kids go every 3 months. My husband goes every 4 months. And when they go to the doctor, it's not just like a doctor's visit. We have to check their A1C, which is a lab test, so we have to pay for that. They download the continuous glucose data, and to download that and record it and read it, that's a fee for the doctor's charge. That also doesn't include the fact that I have to pull my kids out of school to go to the doctor, and I have to leave work in a lot of cases to go take care of them. So there's just a lot of little ins and outs that go into basic type 1 care. I wanted to point out here, this is one family's representation of what they pay per month to take care of diabetes. So once we buy the pump, that's great. We have the pump for $8,000, but then we have to buy infusion sets and cartridges to hold the insulin. Then we have to have the insulin. Then if we have a CGM, we have the transmitters, the sensors, and the technology to record that information. And then we have all the other stuff, and I'm actually going to spend a bit of time talking about what all the other stuff really means. Again, I would like to say that here I have the Humalog Quick Pen highlighted. As a 3-month supply is $700 retail, that would be about $1,900. So that's after insurance for this individual. Okay, so I have a scientific background, and I knew coming here that I didn't want to just say, it's really expensive, it's bad, right? I wanted to try and get some data from some individuals across a bunch of these Facebook groups that I've been telling you about and see if I could put together kind of a generalized picture from a bunch of different people so that you don't know it's just me that's having this issue, it's across the US. So I administered a Google Doc survey that I made myself. It is slightly biased, I'm not gonna lie. And you'll see in the results it's slightly biased, but it gets the point across. And I administered this to 6 different Facebook groups. You can see that we have type 1 families of the Bluegrass, which is basically a local group of type 1 families that support each other here locally, all the way out to some global groups of adults and children. I focused a lot on the children aspect in this case. I collected information from 478 families or type 1 individuals from 45 states and 3 different countries. So I was able to get at least a good sample of information. You'll see when you look at some of the demographics that age-wise I was biased towards the children. So the children make up most of my survey. I do want to point out that if you look at the number of type 1s in the household, we had 57 reports from 2 type 1s in the household, 3 reports from 3 type 1s, and 1 report from someone who had 4 type 1s in their family. So again, thinking about how these costs will escalate. Most of these reports of over 80% had private insurance, so we're looking at both low and high deductible insurance there. And then the rest of them had some form of government insurance. I did want to figure out kind of really what people are paying and how that's related to their income. And so if you look at the top figure in the red and blue pie chart, parts of the pie chart, you'll see that over 50% of the households that were recorded in this survey made under $100,000 per year for their household. And I would like to say that $100,000 seems like a lot, but you know, after taxes and after treatments, it disappears really, really quickly. On the bottom chart, I asked individuals what was the average amount you spend on diabetes supplies a month. And if you look in this case on the purple and the light blue on the top, almost half of the participants pay at least $250 a month. And I probably should have added in another bar for $1,000 or more a month, just to get a real true estimate of what that 500 plus means. So it's a pretty significant out-of-pocket expense each month for these individuals. And this should be after you include insurances. This is really what we're looking at. Now, because this is a pretty biased age survey, what I found was that most of the type 1s, particularly in the lower age groups, have access to an insulin pump. I will say that of the remaining group, 26.9% stated that a financial barrier is the reason that they can't get an insulin pump. If you look at CGMs, the access to a Dexcom, a Libre, there's another one out there from a group called Medtronic, 88% of the individuals do have access to a glucose monitor, and of the remaining, almost 40% said that finances were a barrier. So a lot of people, if you hit your out-of-pocket, which we usually do by March in our family, then you can go ahead and just get as many supplies and build as much as you can. But a lot of people can't hit that out-of-pocket until November, December, because they have a high deductible plan. So it just continues to build, and it really never goes away. Now, what I thought was interesting and kind of scary at the same time was that I asked individuals, what other expenses have we not thought about? We know the big ones. We know glucose monitors, we know insulin pumps, we know insulin, we know glucagon, but what else is there? So here's what they said. So I'm not going to read through all these, but I'm going to tell you that a lot of these things, I was like, oh crap, I didn't even think about that. Oh, we pay for that too. And I highlighted here all of the things that are directly relevant to my family. So some simple things, like it has in here cell phones. My 5-year-old has an iPhone. And he has an iPhone because his teacher can keep track of his information at school, and that information can be transmitted to me. So this whole time when I'm in here typing on my phone, I'm communicating with his teacher about how to treat him. My 10-year-old has had an iPhone for about 3 years, so we can do the same with her. I'm going to go through several different things here and pick out kind of the most commonly mentioned expenses, but really all of these things are important, and virtually none of them go away, okay? So first, food. I had 228 people tell me that food is one of their biggest expenses. And the reason for that is because you have to think about your diet all the time. So when my kids are high, their blood sugars are high, I don't want them eating high carb food. So I have to have low carb food for them so that they can have a snack whenever they want to. But when they're low, then I need to have high carb food because that's the only thing that will save them at that exact moment. So then you have to buy the sugary snacks, the juices. Juice boxes are a huge one. I've highlighted at the top here one of the quotations from the group that I surveyed. Oh my God, how much we spend on food is one of the biggest things, right? And so on top of that, you try and adjust your diet to maybe include healthy food, maybe a lower carb diet. But I've highlighted or presented a picture here of a box that we send to school. So at my kids' school, each of their classrooms has a low supply box so that they can get the sugar that they need at any given time. They also have a box in every one of their specials rooms, so music, art, gym, etc., so that they can have easy access to sugar anytime they need it. And all of that costs money. I would never buy monster packs of Skittles at my house, except for that I have to distribute them to all the different people. Another thing that was commonly mentioned was time and travel. So many people, and we're fortunate we live in Lexington, but many people drive up to 3 hours to get to their doctor's appointments. And then they have to pay to take off from work, and then they have to pay for parking. And then the time that's associated with being on the phones with drug companies. Just a couple weeks ago, I was on the phone with our suppliers for over an hour and a half just to be told, sorry, we can't help you. So it's a constant battle of time and travel. Again, another picture of my kiddos. And I know this seems like a silly picture to add, but I wanted to point out, if you look at my son's arm, that is showing you his Dexcom. That's his glucose monitor that he wears. And you'll notice that we have it decorated, right? So these patches that we use to administer or to apply the continuous glucose monitors, they don't always hold and they don't always last. And they require extra tape, extra adhesive to make that happen. We only use the special patches when we have a special event, because that patch, that Batman patch right there, cost me $4. So and it will last about a week. So there's no way that we can sustain that kind of expense just to have pretty patches. So we save those for the special days. And you can see my daughter has a little purple flower around hers. And so with regard to the tapes and adhesives, over 100 people mentioned how important that was. We have the tapes, we have the patches. We also have, in our case, lidocaine cream so that we can numb their Dexcom sites and we can numb their pump sites before insertion. That is considered a luxury, that is not a need. But for my, at the time, 2-year-old, there was anything I could do to make it better, I was going to make it better. We also use Flonase at our house. Something you might think about is reactions and allergies to the adhesives. So I have amazing parents who came before me who said, hey, if you spray with Flonase before you put the adhesive on, it can actually slow the allergic reaction. Well, Flonase is not cheap either, so you go to Costco and you buy a big pack for $23 and you replace that in a few months. We also then have to use like a skin tack, which is another adhesive barrier, which strengthens the adhesive, but then we have to get those off. So then we have to have the adhesive removers to get those adhesives off. So you see here that everything just kind of spirals. It's, yep, we get them, yep, they stick to you, but it doesn't end there. There's always something extra. I also want to point out that we treat after removal of all of these devices with some sort of aquaphor or arnica or ointment to try and make sure that we keep their skin as healthy as possible. My son in particular, both my kids, are very slim, and we have limited spots that we can put all these devices, and they need some sort of fat in order for them to work best. So we keep them as healthy as we possibly can by using different ointments after removal. And that doesn't even include if there's any infection. So then that would add antibiotics to that picture. I want to mention ketone strips. Ketone strips are pretty popular now, especially with some of the keto diets and low-carb diets, and you're actually driving the price down a little bit on the keto sticks for urine. So if I wanted to go to Meijer right now, I could get 100 keto sticks, urine sticks for $7. And that's great. That is a great option for most people. But if you have a 2-year-old who has a stomach bug and is not potty trained and is dehydrated, it is almost impossible for you to get a ketone reading before a problem occurs. So in order to do that, we would have to collect urine in a cotton ball inside the diaper and put it onto a urine stick. But if they're dehydrated, they're not urinating. So then they develop these blood ketone meters, which are great, but if you go on Amazon right now, they cost anywhere from $35 to $70 just for the meter. And then if you look at the strips, it's $21 for 10 strips. So if you think about trying to keep track of ketones, which will land us in the hospital in 10 minutes if we're not careful, then we need to make sure that we have this meter so we can check it, but then we only buy enough so that they don't expire because they cost too much. And those are not necessarily, in almost any case, covered by insurance. My kids, since they wear insulin pumps, we have to buy pump belts. So the pump belts allow them to wear those pumps anytime, all day, 24/7, and those cost on average about $25 a piece. Again, we pay for those out of pocket. There's no help with insurance. One of the important things I wanted to mention were diabetes camps. My daughter goes to a camp where every kid there has type 1. Every kid stops to check their sugar at everybody at the same time. And it is a huge cost to us, only $550. And I say only because the out-of-pocket for the camp would be about $1,250 to $1,500 per child. And they fundraise and fundraise to help our kids. So what's the impact of these barriers? Well, the first thing is that we can only get new pumps through our insurance every 4 years. So our family is currently ancient in the technology world. We are so far behind on the newest technology. But I can't afford to pay $15 a pump, $1,000 a pump out of pocket. So I have to wait until my warranty is up and then wait until my pump breaks. And then insurance will agree to cover a new one. And if you don't have these options, if you don't have the access to the insulin, all of a sudden you're going to have decreased blood sugar control, which then can lead to complications later in life. One of the things I didn't include on here is the fact that it does lead to bankruptcy and loss of houses. Significant credit card debt, especially immediately after diagnosis. And then finally, death. We've seen more and more reports recently about death due to loss of insulin access, particularly in the age group of 26 to 30, because that's when they lose access to their parents' insurance. So how do we fix this? So first of all, change in lifestyle is the biggest one. At our house, as soon as we started getting all these bills, we cut cable. We took away gymnastics, we took away extracurriculars, we got rid of any extra stuff that we just didn't use, we got rid of Netflix, we got rid of all the stuff, right? Because we don't need those, we need insulin. 84% of our responses said that they changed their lifestyle after diagnosis. One of the things I wasn't expecting is that when I asked them how they've changed their lifestyle, one of the biggest things is related to stress and sleep. So if you look at my responses, about 100 individuals commented that their lifestyles changed because they're tired all the time, and that can then impact their work life and their day-to-day life. They're anxious because at nighttime, you never know what's going to happen, so you're up all night. And then they're basically changing everything in their life. And so this one down here on the bottom is important. These kids are getting what they need, but the parents aren't. So we'll give up everything we possibly need to take care of our kids. Next, I want to point out that people are traveling to and or moving to different countries. So there was a recent big push from Bernie Sanders. He went with a group from Michigan to travel across the border to Canada. They can go across that border and get 3 months supplies. They cost $35 per vial of insulin there. Huge savings even with their travel time. So they get a caravan together and they all go. Mexico's the other big place. Now the problem is if you live in the center of the country, it's a little bit harder to get across the border. So there's a push to allow us to order and import insulin. Okay, next. Moving to a different state is an option. So Colorado is the first state to put a cap on how much people are allowed to charge for insulin. So their cap is at $100 per month, and Minnesota is in progress in trying to get the same cap placed on their patients. Some states like Michigan and Massachusetts in particular are the ones I'm familiar with, have a special insurance coverage for kids, which covers all type 1 care at 100%. So my mom, I'm originally from Michigan, is begging me to move home. She's like, it's going to be free, right? Just move home. Rationing doses is where we start to see a lot of news coverage. And that's where we start to see a lot of people dying because they try and ration this little bit of insulin that they have, and it causes them to either skip doses, miss doses, underdose, and they can ultimately die from that. In our house, we don't skip doses and we don't necessarily ration, but when we fill up an insulin pump cartridge, if we don't use all that insulin, I pull out the remaining and I use it in my husband's pump. So he gets leftover insulin, and we save a lot of, see, my poor husband, right? So he gets the leftover insulin. It's good for 28 days outside of the vial. So we just go ahead and use that, and it helps us save a lot of extra money on insulin. Another common one is to eliminate the use of pumps and CGMs. We in our house also use our equipment for longer than they're intended. So our CGMs are approved for use for 7 days, but some fabulous people came in and found out that there was a hack that you can just restart the sensor and continue to use it. So my kids usually get about 14 days out of their sensors, and my husband can get 3 to 4 weeks. A lot of people don't change out their lancets, so the thing that they use for finger poking. Yeah, gross, right? Oh, it kills me. It makes me cringe every time. But they may use that lancet for 3 to 4 months to a year before they actually change out their lancet. And that it could also include syringes. And so, you know, you think about the trade-in supplies for like drug users to be able to go trade in syringes. I've often wondered if we should be pushing for insulin users to save their syringes and just go to the trade out. I mean, that's really horrible to say, but maybe they can get more syringes that way. Fighting and lobbying is a big thing right now. We've seen more and more protests at the drug companies because it's unacceptable that they're charging so much for the insulin. We have hackers that have come up with ways to bypass the programming on the insulin pumps, and they do what's called a loop. So they have programmed themselves the mechanism to have the CGM and the pump speak to each other. Now, the thing with this is that it requires upfront money. So you have to buy out of pocket the older versions of the pump from random people who are selling them, say, on eBay, and then you have to come up with the money to get that whole process started. One of the things that was shocking to me, and it shouldn't have been, was that 80% of the individuals that responded to the survey were not aware that there are any patient assistance programs. And I was one of those people. I knew that there were certain programs through the drug companies that you can apply for to get reduced insulin costs. However, a lot of those are only if you have no insurance, or you meet a financial income-based requirement. There are a few other programs like test strip programs, and I found this new program called Will's Way based out of Indiana that supplies some grants to individuals. But there's very little known about what programs are out there, and in my opinion, there's not very many to help people. I do want to touch, I know we're running out of time, but I want to touch on the Walmart insulin. People are pushing right now saying, hey, you can just go to Walmart and pay $25 a vial, and you don't even need a prescription for insulin. And they're saying that this should be our solution to fixing our problem for our cost of insulin. Well, a couple of problems. The first thing is that the time profiles are nothing near what people are currently using to treat their diabetes. So for the long-acting insulin in the prescription that we would use, it's a 24-hour acting insulin. At Walmart, it's more like 16 to 18 hours. So your dosing has to be different to cover the 8 hours that you weren't getting from that insulin. You have to plan and treat differently. The onset of action for the short-acting insulin is much longer. So you may need to pre-dose for a meal an hour beforehand versus 15 or 20 minutes. And if you don't know that, then you're not getting the insulin that you need at the right time. So it's actually not better. And this quote from one of the Facebook users I love is, Walmart insulin is not the answer to unaffordable insulin. It's like putting dirty gasoline into a new Maserati. Because really that's what it boils down to, is you are not getting the same quality of care that you would if you're able to afford your insulin. Okay, so I have some final thoughts, some final comments, and you can see these online. I'm not going to go through them all individually. But the basic ideas here are that things like insulin pumps and things like CGMs shouldn't be considered a luxury. They should be considered the standard, and therefore the standard needs to change. And the same goes for insulin. And my favorite and most succinct comment down here at the bottom. It just sucks, right? So it sucks that we have to even worry about any of these issues. If you're paying 30% of your gross pay to pay for insurance and then all your fees on top of it, how do you ever really get ahead? So again, you can see those online, and I'll just end here with the symptoms of type 1 so that everybody can see and be aware in the future. So thank you for your time. I'm sorry I went over.